So glad to have you all here today. I'm Praveen from Annova Solutions, where I lead the training and quality teams for the risk adjustment coding CDI and HADIS. You can see my introduction here. Today's session is all about audits, an essential part of ensuring accuracy and compliance in our work. Our main spotlight is going to be OIG audits, but we'll also touch on a real RADV sample that we have to bring some practical perspective to the discussion. All right. So before we get started, let's just take a quick warm-up poll that I want all of you guys to take. Now, you can't click on the screen, obviously, so you can send in the points that you think that applies to you in the chat box that we can pick it up from there. So there's more of a warm-up exercise that I want you guys to look at. So we'd like to know how audit ready do you think your organization is today? It's great if you are already doing most of these checks. If not, there's a lot of actionable insight waiting for you in this discussion. So I'll just briefly explain the points that are here. Mock RADVs are becoming quite popular today, and for good reason. They are an excellent way to mimic regulatory audits, evaluate readiness, and take corrective actions before it's too late. On the other hand, HRAs, health risk assessments, are a bit quite notorious of late. They're increasingly viewed as tools to maximize HCC recapture, as we call it, and add new codes, often without any consistent follow-up in the PCP or any other clinical notes. This has put HRAs under the OIG microscope, and our question is, are you doing anything about it? All right, so next is analytics. Analytics, not the kind that boosts your risk scores, but the kind that prevents clawbacks. The question is, who will find the patterns first, you or OIG? Then a pretty simple question about coding tools and coding platforms. But again, we're not talking about platforms and tools which speed up chart reviews, which increase productivity. We're talking about intelligent error prevention. Do you have tools that, are you confident that you have tools that prevent errors which the regulatory audits are picking up? Because we see that a lot of mistakes here are quite, they're avoidable mistakes, to be straightforward. They're quite avoidable. And you've seen a bit through our presentation that how these small preventable mistakes, which can be incorporated in your tools, has actually led to costly audit recoveries. Finally, something very basic, which is the record retrievals. How prepared you are that we know that everyone is getting the audit notices nowadays and the enrollee lists, but we all know that these audits are like pretty old, 2018 and 19. How prepared you are to locate these 8-year, 9-year-old health records if CMS or OIG asks you for them, right? So a lot of audits do depend on our ability to retrieve records. Do you have that ability to retrieve records? Because these might be records which are retrieved, which might require retrieval on foot or manual retrievals, which what we say that you might have to send someone to the facilities. Do you have that capability? Do you have that flexibility that you can retrieve records from the sites? So just take a moment here and rate yourself here, and if the rate if you're doing a lot of things, great. If you're not doing a lot of things, obviously there's a lot to discuss throughout our discussion. I'll just pause here for a second and then I'll move on to the next slide. Okay, very simple, very straightforward things that we have kept here. Nothing extraordinary, but yeah, we find these things very important because the best things in life are very simple. So what we found and what you can take away from this meeting, because there are a lot of rules that keep changing nowadays, right? That a latest rule is that, okay, the extrapolation might not affect health plans, but still there's a lot to take away from here. There's a lot of things that we can do to our quality checks. There's a silver lining here. What OIG is doing, what the regulatory audits are doing, can provide us a framework on how we do our qualitative checks. And we have something that OIG is doing. They're pretty quite smart people, and then we can apply these logics to our own quality checks. So the OIG foundation that we are talking about here is one diagnosis, one claim. You might be aware of this, you might not be, but we have gone through a lot of OIG audits, and it is pretty clear that what they're focusing on the HCCs, the ICDs, which are submitted for the enrollee year that they call the enrollee year. The diagnosis is coded or submitted only once per year, right? It is very unlikely that these chronic conditions or HCC or risk adjusting conditions should be coded only once or submitted only once in a year. So that is something that they're looking at. And they have drawn a lot of conclusions and they have refined their analysis from that. Then we'll talk about how CMS has taken this to a next step and even made it smarter and efficient in creating their RADV samples, which we'll see in the RADV sample that we have. Yeah. So the takeaways are pretty straightforward. That how you can be audit ready. That is the obviously the takeaway here. That how you can be audit ready, how you can plan your own analytics, your own efforts to make sure that you are safe when the audit is around the corner. But more than that, we feel that these checkpoints, that these checks that we are going to discuss today are not just relevant for audit readiness, they also help uh, improve the overall health plans performance. These improve the star ratings, these improve the HERIS ratings, these close gaps, these help with a lot of financial aspects of a plan's performance. So I'll just move on to the next one. So we have gone through 10 plus OIG audits. Actually, we have gone to around, I think, 12 audit reports. Every audit report is around 70 pages. So almost at 800, 900 pages of audit reports we have gone through. And we have decoded some patterns. Some patterns are very straightforward. Some patterns are very intuitive, but some we have compiled, there are several findings, but we are focusing on a few very crucial findings which have a maximum impact that you can take away from here. And the key takeaway obviously here is that we can mimic what OIG is doing, we can mimic what they are doing and incorporate that into our own quality checks and get better. All right, the big one is HRA. Yeah, so HRA is the health risk assessments, right? The health risk assessments are used, at least that's what OIG and CMS claims, and there are a lot of findings. OIG has published a report just for HRAs that they say that HRAs are used by health plans to maximize the risk scores by increasing the recapture rates. Obviously, the condition, an HCC or risk adjusting condition, which was present in 2024, they want that condition to be captured in 2025 in the initial annual wellness visits. So nothing wrong with that. The only problem that they have with that is you recapture it, but you also follow up. You treat that condition. You follow up that in the clinical notes. You follow these things in the clinical, the PCP notes. That is where there is a drop. That a lot of conditions, like for example, cardiomyopathies or some rheumatoid arthritis, which is there in the HRA, but then there is no mention of that condition in the follow-up visits throughout the calendar year. That is what they are focusing on. So the idea here is that they are focusing on the single HCCs and they are categorizing those HCCs into various buckets that where they fall. HRA is one big area that they are looking at. Auditing one-off HCC codes, again, that's the continuation of that. That is the core of this, of all the findings of OIG, that they look at ICDs and HCCs which are coded once in a year in a physician claim. Why does that happen? Why is there depression or a DVT coded only once in a year? Why is there a pressure ulcer which is documented and submitted only once in a year? These are not conditions that get resolved by seeing a physician just once in a year, right? So this is the main focus of OIG. This is the main focus, as we can see, we'll see in the RADV audit also, that this is the main focus, and they build on that, right? They build on that these HCCs which are mapped from single ICD for the entire year from a physician claim, these can be the miscoded, mistyped, or these can be unsupported diagnosis. How do they come to that definitive conclusion, they don't really have to reach the record reviews or the record requests. They can come to that conclusion much before that, before they ask the plans to share the associated records with these. Acute and life-threatening conditions. Obviously, again, these are single ICDs which are coded. For example, the acute myocardial infarction and the CVAs, the fractures, which they see in single physician claims. Obviously, that is something that has been there for ages now. I mean, everyone knows that these conditions coded from outpatient, there is a high possibility that it is an error, right? Unstable angina coded from outpatient, myocardial infarction coded from outpatient. Now, it is possible that a patient is seen to have, let's say, left-sided weakness in a clinic and then immediately admitted to a hospital. But these are very rare cases. Most of the cases, these are follow-up visits, and the physicians have documented that as the acute condition, and the coders have coded them as acute conditions, which become coding errors, documentation errors, whatever you call it. But end of the day, these acute and life-threatening conditions coded from outpatient setting, from physician claims, that is one-off, are definitely under scrutiny. Now, this is a 60-day before and after rule that they are following. This is specifically for myocardial infarction, because myocardial infarction, you know that it stays acute for 4 weeks, right? So it is possible that the patient got discharged from a hospital after a myocardial infarction, and the physician is still in that 4-week window and still treating it and can code it as an acute, document it as an acute myocardial infarction. So what they do is they look at associated hospital claims. If there are any associated hospital claims which support these conditions, then all right. If not, then they definitely pinpoint this or earmark it for an audit. Now, matching diagnosis with pharmacy claims. Now, this is something that not outrightly documented as a finding by OIGs. This is something that we have inferred, that OIGs do a cross match of diagnosis with corresponding pharmacy claims and all the Part D data that is submitted, right? The very important, the very popular one is vascular claudication that we have all seen. That if there are any one of you here that who have received a CMS notice recently, because everyone is getting nowadays, right? A very important condition that is being audited is peripheral vascular disease or vascular claudication. How did they manage to pinpoint on that condition? Our theory is that they checked it with the pharmacy data, right? A vascular claudication, mostly these are diabetic patients. Diabetic patients suffering from vascular claudication are often coded that is how the claims suggest. But when they look at the pharmacy data, when they look at the medications, they find medications which are related to neurogenic claudication, like gabapentin and pregabalin, right? So they see that the medication is there for neurogenic claudication, but the claims suggest vascular claudication. That was one interesting finding, and they digged on it, and they have found thousands and thousands of erroneous data that suggests that claudication, I think the claudication was mentioned or documented by the provider. He might have suggested, he might be treating a neurogenic claudication or a polyneuropathy or a peripheral neuropathy, just mentioned as claudication. But as we all know, physicians are not coders. Claudication as a standalone code will by default lead to a vascular claudication code, right? So vascular claudication is a peripheral artery disease, a PVD. So the coders will code PVD. Nothing wrong with what coder is doing. That is one theory. The other theory is it was actually documented as neurogenic, but the coder incorrectly coded as vascular. Irrespective, what has happened, vascular claudication or PVD is in the claim, and a neurogenic claudication medication is there in the pharmacy data. So that is the focus of audit. I'll show you the actual data from a RADV sample, and you can actually see that this is the focus of the audit. So I'll just move on to the next slide here, and we'll show you. This is our analysis. We have toned it down. We have made it fairly simple of the sample, the CMS RADV sample that a health plan that we have worked with. The health plan has received this, has you all know that the 35 members is RADV enrollee sample that CMS is sending them, right? And we have just broken it down, and we have just confirming the findings that is uh, in alignment with OIG's findings. As you can see here, these are the top 5 HCCs and ICDs which are part of the audit. As you can see, the first is peripheral vascular disease or PVD. And that is the first thing that is in the audit scope, which is almost like you can see 83% of the sample, or 83% of 35 people are suffering from vascular disease, or at least that is there in the claims data. But as I said, there is no supporting pharmacy data to it, or maybe there's a conflicting pharmacy data that treats neurogenic claudication. That's what CMS has also picked up. Mood disorder, depression, bipolar disorders, unspecified depression, unspecified major depression is a major focus of the audit. And why is that? Again, this is what CMS has picked up, the single ICD, the ICDs from the specific HCC, which is coded only once in a year in a physician claim. Why would a physician only document major depression only once in a year? It is a chronic condition. It should be there. It should be coded at least 3 times in a year, right? Even if the medication refills are happening once in a quarter, it should be documented more than once, right? And how they confirmed or how they pinpointed this diagnosis is again absence of the depression medications, the SSRIs, the SNRIs were not there in the pharmacy data. So there is a major depression documented, coded, submitted once in a year, but there is no medication to support that. So that makes it to qualify for the audit. 63% people in this group are suffering from diabetes. Obviously, whenever you see vascular disease, a lot of them are suffering from diabetes because we're talking about diabetes with peripheral vascular disease is a fairly common condition that is coded. 46% of the people in the sample are suffering from heart failure. We'll show you that heart failure is not the focus of the audit. The focus of the audit is the disease interaction factor. COPD, unspecified COPD, is present in 57% of the cases. You can see that 4 of the top 5 ICDs, which are part of this sample, are all unspecified codes. Now, unspecified codes do not have a really high risk score. Then why are these here? Right? We'll look into it. Right? There are acute conditions. Average HCCs per member is 7. Average ICDs is 12. So it's a pretty heavy ICD heavy member list that we are seeing here. Right? As you can see, the diabetes that you can see here, the diabetes with PVD 1151, that is the diabetes with peripheral vascular disease, is one of the most common condition that is being audited. So the disease interaction factor, that's where the heart failure in this sample is making sense. Now, 46%, that is 16 people out of this list, are suffering from congestive heart failure. As you can see, all of these heart failure patients are benefiting from the disease interaction factor. The patient is suffering also from a diabetes or suffering from COPD or maybe both. But in all these cases, the member benefits from the disease interaction factor. That's why heart failure is there in this group. There might be a lot of heart failure patients in the plan, but they have focused on the heart failure patients who are also benefiting from the disease interaction factor, specifically members suffering from diabetes and COPD. As you can see here, 12 members suffering from heart failure out of 16 are also diabetics. All 16 of the heart failure patients are suffering from a diagnosis of chronic obstructive pulmonary disease. So definitely, disease interaction factor is one big area of audit in the RADV, which is not there directly documented in the OIG findings, but it is there. We have found in our findings in the RADV sample, the disease interaction factor obviously is a great interest area for the regulatory audits. Now we'll summarize that what are the HCCs which have the highest audit exposure, right? Based on all the audits that we have reviewed, we have all the audit reports that we have reviewed. We have just summarized it here, and I'll give some examples here. HCC is amplifying risk scores through disease interaction I just mentioned, like diabetes and congestive heart failure. So if you have members suffering from heart failure and diabetes, they are going to be under the microscope for the OIGs and RADVs. Acute conditions is pretty obvious. Acute conditions from the outpatient visits, like a CVA, which is present in the physician claim, right? Then they look at if there is any subsequent hospitalization. If there is not, then definitely it is a high risk HCC for audit. Unspecified ICD codes, even though unspecified ICD codes do not really have a very high risk score, but still they do sometimes these are one-off codes, so it is possible that these are coded incorrectly or these are actually not present in the members, right? And they also contribute to disease interaction factors. One HCC code for the year in a single physician claim. Again, the same concept here. This is their anchor for OIGs and RADVs. One HCC or one ICD, which is coded once in the calendar year, or submitted once in a calendar year in the physician claim, is under the microscope. Now, what I have mentioned here is as an example is pressure ulcer stage 3. Now, it is extremely unlikely that a member or a patient suffering from pressure ulcer, that to stage 3, will get a treatment only once in a year and get all right? Definitely these conditions should be looked at several times in a year. So these conditions should be present in several claims in a year. So if a condition like pressure ulcer or condition like lung cancer is only documented and submitted once in a year, something is definitely wrong. Diagnosis is unsupported by pharmacy data, like major depression without SSRIs, right? Again, they're building on the single ICDs which are present in the sample. The single ICDs unsupported by pharmacy data. The pharmacy data is something that they look at parallelly, and they look at that, okay, depression is there or DVT is there, but there is no anticoagulant, there is no SSRI. So something is wrong. The last one is pretty interesting, very difficult to pinpoint. And at the same time, even if you are doing some internal checks, it can be a challenge to identify these conditions. Conditions which are miskeyed, or when a coder is just typing the codes, they might make a mistake. I've taken one example here, but it is a fairly big focus for OIGs, that the conditions which are miskeyed, for example, this I10 is hypertension, you all know I10 is hypertension, and I11 is hypertension with heart failure. It is fairly easy for, or it is quite possible, it is seen fairly frequently that coders do get confused between the I and 1, and they might end up typing I11 instead of I10, which unfortunately what happens here is that code is still risk adjusting, but now it has a higher risk score. Now it becomes, the hypertension becomes hypertension with heart failure. And how do they identify that it is good for audit? They look at absence of heart failure in the documentation, right? If there is hypertension and heart failure, I11, and there is no associated code of heart failure, then definitely something is wrong there. That is a potential miskeyed diagnosis, which is fairly interesting and fairly important. We consolidated some findings in percentages because percentages are attractive. 30% of records submitted have no documentation of the submitted HCC. Now, this is when the notice is sent to the health plan, and now the health plan is supposed to send the records which support the HCCs which are under the microscope. Now, the health records, the medical records which the plans are submitting, 30% of the submitted health records have no documentation that suggests the HCC which is under the scrutiny. And there are almost 10% of HCCs for which health plans are unable to produce any record. These are all 8 years and 9 years old records. So even if I would like to combine this 30 and 10 and say that the success of a RADV audit hinges on the successful retrieval of health records. If a health plan is submitting a record which does not support, or where the ICD is not at all documented, definitely they are not able to find the appropriate health record for that. Do you have the capability? Are you working with vendors who can retrieve the records for you in the old-fashioned way? They can reach out to the facilities and the providers and get the records for you. The success of RADV audit often depends on that, because a lot of times health plans are just not able to retrieve those records to support these HCCs. 25% of records do not support the HCC in audit and suggest HCCs that were never submitted. That is money left on the table, right? So when we say that we would like to be prepared for the audit, we think that, okay, we might have to send some deletes to CMS and our risk score will actually come down. But there are 25% of cases where OIG has found the conditions that were there, the risk adjusting conditions, which the plan should have submitted but did not. Right, so that is money left on the table. Even if you do your own analysis, it's not that you will end up reducing the risk scores. You will find a lot of conditions which were not submitted at all. So that is 25%. And greater than 5% of OIG findings, if you send appeals, or RADV findings, if you send appeals, your appeals will get accepted. That is what the data shows us, that don't shy away from contesting the audit. If you are fairly confident that your HCC has supporting documentation, do contest it, even if the preliminary reports or the findings say that the HCCs are unsupported. Do contest it, because we have seen the data supports that in almost 5% of cases, or greater than 5% of cases, CMS will accept your appeals and they will reverse their decisions. Right now, if you're lucky, it is quite possible that what if there is the 5% of HCCs which are getting the decisions are getting reversed are very high risk HCCs and HCCs which have very high risk scores. You never know. So the process is not done when you have retrieved the records, coded them, and submitted them to CMS. You wait for the findings and contest the findings if you can. Right? Don't leave any money on the table. Now, how to succeed in a RADV environment? So we keep coming back to this one point, that diagnosis on only one claim during the service year. We keep repeating ourselves because that is the most important factor, that is the cornerstone of all the audits. They focus on these HCCs or ICDs which are coded and documented and submitted only once in a year. So you have to, if you are doing your own analysis, focus on these HCCs, on conditions which have been coded only once. Right? Validate single claim HCCs. Divide them, categorize them. You might end up with 50,000 or 100,000 members. You cannot audit all of them. So how do you prioritize? You categorize these HCCs, one-off HCCs, into acute, subacute, and chronic conditions, right? And then look for supporting documentation. If it is an acute condition, if it is a CVA, look for a hospitalization. If you find it, don't include that in your internal audit, right? Subacute conditions like what? Like pressure ulcers, like lung cancers, right? So if they are coded only once in a year, definitely these conditions should be coded or documented more than once in a year. A pressure ulcer takes months to heal. If it is documented and submitted only once in a year, something is wrong. You have to pinpoint that for audit, right? And definitely look at the medication support, the DVTs, the chronic DVTs, the isolated unspecified depression codes. Right? Look at the medication data, look at the pharmacy data, Part D data, and look at if there is a supporting medication present or not. Right? Further, you can classify these single ICDs into source types such as HRAs, physical therapy. HRA is pretty straightforward, right? So if rheumatoid arthritis is there in an HRA, but never coded again throughout the calendar year, something is wrong. Physical therapy, if the note is of a physical therapist, it is an acceptable note for risk adjustment. But the physical therapist is diagnosing and coding dementia and Alzheimer's disease. Something is wrong here, right? So these conditions should be coded by a specialist or PCPs, but you find them only in physical therapy notes. That is a red flag. You should be auditing those notes. Medication analysis, there's no way that we can overemphasize the importance of medication analysis. Medications, pharmacy data tell a complete story, or at least it is a great starting point for any analysis, because these are all members, all patients suffering from chronic conditions on long-term medications. There's a lot that can come out of the medication. Just assessing the medication data, you can get endless analysis out of it. Medication mismatches often reveal gaps in care, documentation, coding errors. Right, so there can be a rheumatoid arthritis in the documentation, but no associated medication. There can be a disease-modified anti-rheumatic drug in the pharmacy data, but there is no rheumatoid arthritis, or maybe there is just osteoarthritis. It can pinpoint to coding errors. It can identify documentation errors by the providers. It can provide a starting point for you to identify where the problem is, right? Neurogenic and vascular claudication, we have discussed that. Patients suffering from vascular claudication or neurogenic claudication, but the associated medication is not there, right? So that gives a hint on where the documentation might have gone wrong, or maybe the coding has gone wrong, right? And it just doesn't stop there. The medication analysis just does not stop at your audit analysis. It also enables you in other areas of plan performance. Medication reconciliation is a HEDIS measure. It is a star measure. Polypharmacy management is a star measure, right? If you are doing this, you are indirectly increasing your star measures. You are increasing your star ratings. It's not just you're getting audit ready. You are improving the overall performance of your health plan if you're working on medication. Medication data analysis is a gold mine. We have to understand the importance of it, because we are dealing with members suffering from chronic conditions, right, on long-term medications. You can find unbelievable patterns from the medication data alone. So what is the framework for robust audit readiness? Smarter tools, right? So it's kind of counterintuitive, but it is extremely important. If you are working on smart tools like Annova's, we have our own coding platforms and coding tools, we will just not allow a CVA from outpatient. We will just not, it's not just, it is a human factor that is here. The tool itself is smart enough to not allow a CVA or a fracture or an acute fracture to be coded in an outpatient setting, because the type of visit that in the coding tool we have to enter inhibits the coder to add an acute life-threatening condition from outpatient. Now you can say that there are exceptions where these conditions might be present, but yeah, then these are red flags, and these can be reviewed and shared with the clients, and then we can take a call on that. But the first line of defense is we don't allow these high-risk conditions or these acute conditions from outpatients. We capture the all the ICDs with the specific header from which it is picked. So if there is a breast cancer picked up from past medical history, the tool itself will never allow it to move forward, right? That's how smart tools should be, so that these conditions do not move away from the or there's no human intervention that blocks these mistakes. These tools or these workflows don't allow such mistakes to happen at all, right? Manifestation codes. We discussed about the hypertension with heart failure. If a coder is going to code hypertension with heart failure by mistake, by mistyping, right? So obviously there is no associated heart failure code. So our tool is built in a way that it will not allow the coder to submit that code without the manifestation code. You cannot submit hypertensive heart failure without a heart failure code. You cannot submit hypertension with chronic kidney disease without a chronic kidney disease code, right? These tools should be smart enough to pick up these mistakes, and that's how a lot of mistakes can be prevented from happening in the first submission. There can be pre-claim submission checkpoints which flag unusual or conflicting coding patterns before submission. If you are submitting in a claim two different stages of a same disease, and it is allowing you to do so, then your claim submission system is not smart enough. It should not allow you to submit pressure ulcer of the right hip, stage 3 and stage 2 at the same time in the same date of service, same encounter. It should not allow you to do that. If it is not smart enough to do that, then you need to work with better tools, right? These checkpoints should be there in the coding tools. These checkpoints should be there in the claim submission tools, right? The claim analysis should happen every quarter. Don't wait for the calculation year to end and then do your analysis. Do it in every quarter. Identify the single ICD trends. Now you can say that this ICD, which is coded once in a year, how can you identify that in a quarter? you do a data mining and you find out from a year from that, right? So if a condition is coded, an unspecified depression is coded in March, right? So you look at the claims data from March 24 till March 25 and identify if the condition is coded only once, something is wrong. So you need to have these things inbuilt in your systems. There is a counter argument here that it is not always financially feasible to retrieve records and store records at all times. We're not saying that retrieve records for everything that you have coded and store them in a database. No. Maintain the records, just one record for every HCC that is validated. Right? If you get a notice from CMS, if you are getting audited, it is fairly easy to just pick those records from your database. We are just saying keep one record per HCC. Preserve records that were used. Sorry, so I've written. Preserve records that were used for edits and deletes. If you have done a retrospective audit review and you have used one record to submit an edit to the submitted data, we should store this, right? We see time and again a lot of efforts are repeated. A lot of efforts are it's not very efficient. Like what we are doing. We retrieve records for HCC coding, we retrieve records, the same records for quality measures, we retrieve the same records for HIDIS. And when you get this audit notice from CMS, you end up retrieving the same record again, the third time, right? So categorize records as per the high risk HCC, keep them in place at least for 5 to 6 years. Records should be there. The records which are used for the best record which is used to submit an HCC or a record that is used to send edits and deletes, right? These records and records which are used to submit high risk condition like cancers and all should at least one record per HCC should be stored in some database. Should be creating one HCC accountability team, or maybe you can outsource that, right? These checkpoints are in place, should be owned and monitored continuously. You should always monitor the efforts that you are doing, right? The one big problem with risk adjustment efforts, they are scattered, there are a lot of silos, and nobody is actually evaluating the effectiveness of these efforts. If you are doing a CDI program, are you actually evaluating how effective is that in not just picking up the mistakes, but are the mistakes getting prevented? Do you have a department that checks that, okay, we have done a CDI effort, we have spent so much money, we have invested in a CDI program to prevent mistakes in documentation. But we evaluate that over the time, that is it actually preventing mistakes in a long term? Are providers actually improving their documentation? Are your concurrent and prospective coding efforts preventing mistakes from happening? If the analysis is not happening, you should have a team that does that analysis. The best audit defense is built before the audit even begins. And the silver lining here is that you don't really have to start from scratch. That where do we start? OIG data, OIG findings are pretty good, and we can use their patterns. We can use what they have used, what they have utilized to find errors. We can pick up on these and start our own patterns and start our own quality checks. It is not just to improve the overall quality or the audit readiness of the documentation and the coding. It improves the overall health plan performance. Follow the care, don't follow the codes, is what we always say. If the care is happening, the codes will follow. If the care is happening, the documentation will follow. Right? So these checks that we have in place, the checks that you can put in place, will not just help you in preparing you for an audit. Just like I said, that if the medication is there and the disease is not there, then there is a polypharmacy or there's a medication that the patient should not be on, or maybe it is a coding error. So it will help you close gaps. It will help you in your quality measures. It will help you improve provider and patient satisfaction at all levels. So we are open for questions. If you have any question, please do type in the comment box. We are open to questions. And thank you so much. Thank you so much for taking out time to hear us. Right. No, okay. So that's an interesting question that we have here, that OIG does the analysis at a much later date. Also, you can call it a retrospective analysis. So how do we apply these checkpoints in real time? That the one-off HCC that we are talking about, right? The HCC that is coded only once in a year. You don't have to wait for the entire year to finish before you uh, complete that, before you actually pinpoint that HCC. If there is an HCC which is, you can pick the start date, right? We can, if you find the HCC, the single HCC in March, trace it back to March of the previous year and see if it is coded more than once, right? You can still pick up those patterns. You can pick up those patterns of medication analysis. If there's one unspecified ICD that you see in the documentation, look at the pharmacy data. That do you have any SSRI or SNRI in the medication list? Do you have that? If not, you don't really have to wait for the entire year to do any corrective action. You can still do it. I hope that answers. So, do you recommend mock audits done within a plan by the plan itself, or it makes sense to use outside vendors to do them? I mean, there is no right or wrong answer here. Obviously, you can do it yourself. You can use vendors to do that. It always helps to have a third opinion. It always helps. Maybe your we have all grown up with a lot of coding guidelines that we have been following for 10, 15 years. I have an experience of more than 15 years myself, and there are certain rules that we follow. It's always, it never hurts to have a second opinion or a third opinion and ask someone else to look at your documentation and your coding techniques and share their inputs. Maybe that will help. So if you do a mock audit with a vendor, maybe that will be more effective than your in-house teams. So, but you have to work, let them work independently. Don't give them the coding guidelines that you follow. Ask the vendors that you are working with to follow the CMS guidelines. That's it. Follow the general ICD guidelines and share their findings. Right? Don't let the vendors follow the guidelines that you have followed, because then the findings, your findings and their findings will be very similar, right? So let it be a very independent review if you want a mock audit to be done. Even the analysis for the mock audit, give the claims data to a vendor, give the uh, maybe some EMR access to the vendor and let them come up with an analysis and tell you that here is where I see some problems, and let them review the records and share the findings with you unadulterated. That is the trick here. Right. Can you share some more insight for the miskey diagnosis? Yeah, miskey diagnosis. Uh, we touched upon one diagnosis, which was the hypertension unspecified and hypertension with heart failure. Why? Because the I and the one look very similar. Coders tend to make those mistakes, and it is not so easy to pick up these things because both conditions risk adjust, both conditions can be present, and it is not necessary it is coded only once in a year, but there are patterns. If you have identified conditions in within your database that we have seen these conditions to be miskeyed, we can focus on that and we can narrow down our audit sample, and then we can identify that, okay, hypertension with heart failure is coded, but there is no heart failure. Hypertension with chronic kidney disease is there, but there is no kidney failure there, right? These are patterns which can lead you to define those misdiagnoses. Unfortunately, in the OIG reports that we have gone through, most of the ICDs that they mentioned are ICD-9 codes. So I can't really give a lot of examples here because there's no point discussing about ICD-9 codes here. And these audits are, their findings are pretty old, from 2015, 16, and also the miskeyed diagnosis that they have given us are from diabetes with the 250-00 era that we had 10 years ago. But yeah, we can always pick up patterns and identify conditions which can be miskeyed. Does pharmacy or treatment data really play a big role during audits, or is it mostly documentation? No, that's what we have seen, right? So documentation is the last part. The OIG and CMS will filter what does OIG not have? What do they don't have? They don't have 1,000 coders, right? They don't have 5,000 coders to audit 5 million charts. They don't have that, right? They don't have that budget. They don't have that workforce. So they want their analytics to be so smart that they can pinpoint just 200, 300, 400 members for audit, right? But before that, they do a lot of analysis. And that analysis requires them to look at pharmacy data, align it with the claims data from the physician claims, right? And they have become quite smart at that. They have become so smart that the record review, the actual checking of the documentation is just the last nail in the coffin. And they have already identified erroneous patterns, and the documentation is just an evidence to prove that. So yes, pharmacy and treatment data, the pharmacy data and by treatment, if you mean the procedures and the services, the CPT codes, which are aligned, are they helpful in uh, identifying or pinpointing the members for audit? Definitely. If there is a breast cancer patient, a patient suffering from lung cancer or prostate cancer, and there is a procedure note which is of a prostatectomy or a mastectomy, if it is there, and you see after a year the HCC code is still coded as active. Now that raises some eyebrows and uh, definitely identifies those conditions for audit. So yes, the treatment data, which I think what you mean by treatment data is the procedure codes and the CPD service codes, and the pharmacy data, which is from the Part D claims and the pharmacy, the various pharmacy data that they have access to. They will align that with the physician claims data, and they will come up with an analysis. Definitely. Documentation review is just the last step of it. A lot of analysis happens much before that. Sure that this makes sense and it is helpful for your planning. And if there are any other things that you want to discuss, we are always there to connect. And we'll be sharing these our contact details, and you can reach out to us. Thank you, everyone. Thank you for your time.